So today's topic for discussion is supracondylar fractures of humerus in children. So the objectives of today's talk is to know about the anatomy of the pediatric elbow, that is the supracondylar region, the mechanism of injury that leads to the supracondylar fractures, the classification of supracondylar fracture, especially the most common one, the clinical features associated with the supracondylar fractures, and the radiological landmarks and signs that we use for diagnosis and also the treatment of the supracondylar fractures, the management of the supracondylar fractures, and also its complications and management of that. So, supracondylar fractures are the most common fracture in the elbow of the children. It is almost 70% of the fractures of the elbow is the supracondylar fractures, and the age group is between 3 to 10. And mostly between 6 to 7, and it's more in boys actually. And its importance of supracondylar fractures are mostly the devastating complications that are associated with it, especially the vascular complications, the nerve injuries that are associated in 10 to 20% of cases, and also Volkmann ischemic contracture, which is the dreaded one, by which the incidence is 0.5%. Now, when we come to the anatomy of the supracondylar region, the articular surface of the distal humerus is attached to the humeral shaft via the medial and lateral columns. These columns are separated by a thin area of bone formed by the coronoid fossa anteriorly and the olecranon fossa posteriorly. As you can see here, the thin area of bone connecting the between the medial and lateral columns. This is the weak area, and it is here that the fracture occurs. So when a hyperextension force occurs, the olecranon acts as a fulcrum and propagates the fracture. And it's mostly transverse in children. And so the bony anatomy is the reason for the higher incidence of supracondylar fractures, whereas the neurovascular structures that traverse the supracondylar area is the reason for the devastating complications. So we see the brachial artery and the medial nerve which traverse the antecubital fossa, the radial nerve which comes from posterior to anterior at the level of the olecranon fossa, and also that is laterally, and medially we will see the ulnar nerve that traverses behind the middle epicondyle. So all these are prone for injury in a displaced supracondylar fracture. That is, we'll come to that. The types of supracondylar fracture, the most common one that we usually see is extension type. It is up to 96 to 98%. So you can see most of it is extension type. Very rarely the flexion type also comes, that is only 2%. So it's rarely seen. Extension is the most common, and most of this discussion is regarding the extension type because that's the commonest thing and the one seen day-to-day life. The mechanism of injury in supracondylar is with the extension type of supracondylar, the forearm outstretched hand is there with the elbow in full extension, and the bone gives away in the region of least resistance. So you can see here, forearm the outstretched hand, and displacement of the posterior displacement of distal fragment and the proximal metafacial fragment inveiling the soft tissues. So you can see forearm the outstretched hand with hyperextended elbow, and you can see the distal fragment getting displaced posteriorly and proximal metafacial fragment displacing anteriorly. So most common classification of the supracondylar fracture is by Gartland. It is universally followed. The type 1, 2, and 3 are the types of supracondylar fractures. So type 1 is undisplaced fracture, that is this one. The first one with fracture line propagating toward but no displacement. Type 2 is displaced with posterior cortical contact. As you can see, the displacement is there, but there is posterior cortical contact in type 2. And type 3 is totally displaced. No contact, totally displaced. Now there are some subdivisions to the Gartland classification, that is by Mubarak and Davids, that is for the type 1. This type 1 is subdivided into type 1A, which is fully undisplaced, and Mubarak and Davids has suggested 1B also, which is having medial combination in the coronal plane. You can see the medial combination here, and also some extension in the sagittal plane. As you can see here, extension in the sagittal plane. You can see the medial combination. So this kind of type 1B is usually unstable fractures, and it can lead to, if not treated properly, can lead to deformities. We will come up to those later. So type 1 fracture, as you can see, mostly it is barely visible. The fracture line itself may not be seen initially, but once you immobilize, after 2 weeks you will be seeing this periostal reaction like that. So That is type 1. Type 2 is, as you can see, displaced fracture line with displacement is there, but there is posterior cortical contact, and type 3 is totally displaced. Now, type 3 is also subdivided by Wilkins into posteromedial and posterolateral based on the displacement of the distal fragment. So, posteromedial displacement, as you can see here of the distal fragment, is this one, but usually the importance of this is the periosteal sleeve. The posteromedial one, the medial periosteal sleeve is intact, and the lateral is broken, and the posterolateral lateral periosteal sleeve is intact, and the medial periosteal is broken. So it has some bearing in the reduction of the supracondylar fractures, especially if it is treated by close reduction. Nowadays, when we hold the reduction, only it is important now. Previously, when close reduction and all were used, this was more important. When so the posteromedial fractures, the medial sleeve gets tightened when you hold the once the elbow is flexed and the forearm is kept in pronation. This medial sleeve tightens. The lateral sleeve tightens in supination, but not to the extent of medial sleeve. So this is the posterolateral displacement, which is more prone for neurovascular complications because of the impalement of the soft tissues by the medially displacing proximal fragment. Distal fragment goes laterally, posterolaterally, so it's posterolateral displacement. So structures at risk in both. So you can see in the posteromedial, the radial nerve is at risk. In the posterolateral, the brachial artery and the medial nerve is at risk. Signs and symptoms of supracondylar fractures. So there is always the fall on, typical history of fall on the outstretched hand, and the child will have pain and failure to use the upper limb after the fall. There will be deformity and swelling. Type 1 will be less obvious with polytendinous, decreased range of motion, some angonious soft spot, and reduced range of motion and all. But in type 3, it is quite obvious. There will be a S-shaped deformity like this. You can see the displacement of the distal fragment posteriorly causing the S-shaped deformity. There can be the pucker sign. In all the supracondylar fractures, one has to look for the vascularity, one has to feel the pulse, the perfusion, and look for any neurological injury also. So deformity I have told, puckering, this is the puckering sign. This is due to the impalement of soft tissues by the medial, by the proximal metaphyseal fragment, impaled soft tissues. Sometimes even pierces the brachials and pierces the brachial artery and injures the nerve also. So one has to be very, very careful in this kind of fractures. And now we come to the radiology. The standard views are the AP and lateral views of the elbow. AP of the entire extremity also would be done to see any associated fractures. The AP view of this distal humerus and the lateral view of distal humerus is very important, especially the lateral view of the distal humerus, because it is based on those that the treatment decisions are mainly made. So a good lateral view of the distal humerus or elbow can never be overstated, because that is the most important thing that we need. And the Jones view is for the medial and lateral column, and so one has to get good X-rays, however difficult it may be, because bad X-rays will lead to bad decisions. So what are the radiological signs that we say? They are the Bowman angle, the crescent sign, the fat pad sign, the teardrop or hourglass sign, shaft condylar axis, anterior humeral line, coronal line. These are the important ones. We will see each of those in detail. This is the Bowman angle. It's an angle formed by the long axis of the humeral shaft with the long axis of the lateral physis. Or, as you can see, this is the Bowman angle. Usually it is between 64 to 81, but on an average it is like 70 to 75. Normal Bowman angle. So our aim is to get in any fracture of supracondylar, get an angle between 70 to 78. So Bowman angle increases in supracondylar fractures when there is more varus. And this second reading here, 90 minus alpha, that is the new Bowman angle. The older one was this one. Second radiological sign is the fat pad sign. This is actually used mostly in the type 1 supracondylar, which are usually not obvious in the radiograph. As you can see here, you can see no fracture line here. So this is diagnosed by the fat pads actually. So what are fat pads? Fat pads are normally present in the elbow. You can see normally like that. So when there is a big effusion it gets elevated and it acts like a radiolucent sail. As you can see here, the anterior fat pad and the posterior fat pad. So it indicates that there is a fracture and one has to treat it as a type 1 supracondylar. Next sign is the teardrop sign. From the lateral radiograph of the distal humerus, it looks like a hourglass or teardrop, and the distal part of the teardrop or the hourglass is formed by the capitular nucleus. Any obliteration or shows the displacement of the distal fragment or extension, especially it happens in extension of the supracondylar. Shaft condylar axis is the angle formed by the long axis of the femoral shaft and the long axis of the capitulum in the lateral radiographs. Usually it is 40 degrees. So in extension supracondylar, this angle reduces. Now this is the anterior humeral line. This is one of the most important lines that we use in the treatment. Many of the treatment decisions are based on the anterior humeral line. A line drawn through the anterior cortex of the humerus transects the capitulum in its middle. In extension supracondylar, it usually will be transecting more anteriorly. And this is the coronoid line. The line drawn through the anterior border of coronoid usually touches the lateral condyle on its anterior aspect. In extension supracondylar, usually it will be more anterior. Anterior humeral line, to emphasize the importance, this is how it is drawn, and this is the most important landmark on which most treatment by radiologists are done. Present sign, this is due to the overlap of the distal humerus by the polygonum. This is happening in varus deformities, mainly in cubitus varus. So this is another radiological landmark that is seen in supracondylar fractures. So in treatment goal, I would quote one of the giants in pediatric orthopedics, Mercer Ryan. He has said that the goal of treatment is to avoid catastrophes and minimize embarrassments. The catastrophes like vascular injury and Volkmann ischemic fracture, and embarrassments like cubitus varus, loss of reduction, iatrogenic nerve injuries. So we want us to have this in mind when treating supracondylar fractures. Type 1 supracondylar needs only simple immobilization. As we have seen, it is undisplaced fracture and needs simple immobilization in plaster of Paris. Mostly you can use a splint or bivalve cast, and I keep it at 90 degrees of flexion, and further no extra flexion as it may lead to compartment syndrome. So only 90 degree flexion and neutral rotation, that is what is advised nowadays. And check X-ray after 1 week. The patient child is asked to come after 1 week, and we do check X-ray to see if any displacement. If not, if no displacement is there, just continue the plaster for 3 weeks. After 3 weeks, the plaster is removed and elbow is mobilized. And the parents are asked to bring the child back after 6 to 8 weeks to assess the range of motion and all. Mostly it will be back to normal by that time. So the most important advice that we have to give the parents and children is regarding the limb elevation. Mostly if you send in a sling like this and ask them to keep the limb elevated, they come back with edema, pain and all. So first 48 hours, the child has, the parents have to be told that the fingers has to be above the elbow level and elbow has to be above the heart level to avoid swelling and edema and pain. The treatment of type 1B, as we have seen before, explained by, that is the Mubarak classification 1B, and the type 2, that is the one with the posterior cortical contact. Previously, these were treated by close manipulatory reduction and cast immobilization. But the current teaching is if there is significant medial collapse, then close manipulatory reduction and pinning with KVR and CM is the treatment of choice. Because the treatment in plaster in these cases needs hyperflexion, and also there is chances of in the plaster of Paris, and there are chances of loss of reduction in the cast, and also chances of compartment syndrome because of the hyperflexion and vascular injury. Type 3, there is only one treatment. The treatment of choice is close manipulatory reduction and KVR fixation, and that is close reduction and pinning, and usually the pinning is pins are kept for 3 weeks. So how is the reduction done? Traction, longitudinal traction, even with elbow in extension with supinated forearm. Varus and valgus is corrected, angulation is corrected in this position along with the rotation of the distal fragment. Now with the pressure on the posterior, this is how we do it. Now once that is done, a pressure is applied on the proximal fragment posteriorly, and the you milk the olecranon anteriorly, and once we are doing that with the non-dominant hand, we will flex the elbow. So once the elbow is flexed, reduction is obtained, forearm is pronated for posteromedially displaced fractures to tighten the periosteum medially, and supinator for posterolateral fractures. We assess the reduction in AP and lateral in hyperflexion and maintain it like that, and then we go for the pinning. So these are the pinning techniques, the two lateral pins, as you can see. The commonest one is two lateral pins that are used parallel. So you can start in the midline, and there is a concept of 1/3 to keep the pins as much as away from other and avoid crossing of the pin at the fracture site. The most important thing, principle in the pinning technique is to keep the pins as far away from each other at the fracture site, so that the rotational stability is there. So this is parallel pinning and this is cross pinning. Pinning techniques, we use 0.625 KYS, a parallel or cross fashion, and also selective medial pinning also can be done. The pins should never cross each other at fracture site, as I told you, so it should be parallel. It should never cross at the fracture site. So the pin should be at maximum separation at the fracture sites for rotational stability. And the concept of 1/3 helps to keep the pins apart. Now there is the medial pinning. So the medial pinning is done only selectively. Mostly it is lateral pinning. Medial pinning, why the cross pinning is less popular is because of incidence of ulnar injuries that happens with the medial pinning. It can be avoided by pinning with the elbow in extension, so that the ulnar goes posteriorly, and also by milking the soft tissue of the elbow before doing the pinning. And after pinning also avoid the elbow flexion in immobilization, because the ulnar nerve may get tented by the pin. So if you see any nerve injury after medial pinning, one can try to extend the elbow and see if the nerve injury recovers. If it is not recovering by that, just remove the pin. Usually it gives good results. The nerve recovers. So the gold standard is 2 lateral pins and 1 selective medial pin. So 2 lateral pins are applied, and so some posterolateral fractures that may not be enough. So in that case, we can use the medial pin, but we can do it with the elbow extended because of the safety net of the 2 lateral pins are already there. Now there are proponents of the divergent pinning. This also is equally common. So divergent pinning for type 2, they use 2 pins in divergent manner like that, laterally only, and for type 3, 3 lateral pins like that. So here also, as I told before, any kind of pinning techniques that one uses, the most important principle is to keep the pins as far away from each other at the fracture site, and to get good hold posteriorly, proximally and distally, so that there is good rotational stability. So once one is happy with the fixation and stability, one can cut the pin short and use a felt pad to protect the skin and immobilize in 30 to 60 degree flexion with no constrictions. And mostly it will be by splinting only, and if cast is used, by weld cast. So the acceptability criteria, these are anterior humeral line, which we have seen before. It should transect, once it is the fracture is reduced, it should transect the capitulum. A Bowman angle of 70 to 78, and intact olecranon fossa. Also, people say about intact medial and lateral column. So other options of treatment, open reduction. This is done only when close mandibular reduction is not possible, or multiple close reductions not getting proper reduction, especially when you have seen the pucker sign in those cases where the soft tissue impales or in between is lying between the fracture sites. Or mostly but those are rare. Most commonly it is in open fractures or associated vascular injuries, one has to do the open reduction. Open fracture, of course, one has to do that after debridement and fixation. And also vascular injuries, one may have to open by the endomedial approach. Now, this is another treatment method, the olecranon wing traction and overhead traction. Nowadays, not at all used. It is of historical importance, and mostly for unstable fractures or fractures that are difficult to be pinned or held for 10 days traction, then when the fracture gets sticky, you cast immobilization. But the high incidence of complications, the compliance, all has led this to be obsolete now. Now we come to the complications of supracondylar fractures. The complications are namely vascular injury, malunion, Volkmann ischemic contracture, nerve entrapments, elbow stiffness, myositis ossificans, non-union, and AV nerve trochlea. So the first four are the commoner ones, and those cause devastating complications. Elbow stiffness, myositis ossificans, non-union, and AV nerve trochlea are relatively very rare. The vascular injury occurs in 10 to 20% of type 3 case. Type 3 supracondylar present with an absent pulse. So that is the most important thing in supracondylar fractures. Actually, in various literature it is mentioned between 2 to 38%. So that much can present with an absent pulse. So the most important thing is to when you see a child with an absent pulse, try to extend the elbow and see if the pulse improves. So that is mostly with a slight extension of the elbow itself, vascularity improves. So if vascularity is not improving, or any child with an absent pulse, the treatment is post manipulated reduction with K-wire fixation. And once you do the K-wire fixation, allow 10 to 15 minutes for the perfusion to recover so that the vascular spasm settles and mostly the perfusion will be back. If not, then vascular respiration has to be done. So this is a flow chart for pulseless supracondylar fractures. So in emergency department, general traction inflection to 30 to 45 degrees, try to realign the fragments. If the vascularity is not at all improving, reduce immediately and pin, or if you get a well perfused limb after the pinning, standard post-op care is enough. If well perfused, still no pulse, that is a pulseless pink hand. This is the area of controversy. So one has to admit and observe and have a high index of, one should be on the watch. If any incidence of loss of vascularity or reduction in vascularity or impending compartment syndrome, one has to intervene immediately. So that is the gray area. And then poorly perfused and no pulse, there is no question of waiting, just go for exploration and vascular concentration. So the dreaded complications of Volkmann ischemic contracture. So one has to be very watchful. Look for any undue pain or pain out of proportion of the injury, and persistent pain is one of the most important signs in Volkmann, the impending compartment syndrome. So any undue pain plus one of the positive signs like pain on passive extension of the wrist, then tense or tender forearm, absent pulse, reduced capillary filling is a warning sign. One has to extend the elbow, all the dressings are removed. If no improvement, it goes for urgent action. Compartment syndrome leads to necrosis of the muscles and nerves, which is irreversible and can lead to fixed length phenomena of the forearm muscles. So one has to intervene very early and treat it well. Now, the most common complication in supracondylar fractures is the cubitus varus. The incidence varies from 0 to 50% in various literature. It is mainly due to the malunion of the supracondylar. It leads to a gun-stroke deformity. It is an angular deformity due to the residual coronal angulation and aggravated by malrotation and hyperextension, mainly angulation. And it is primarily a cosmetic deformity. There is some kind of fixed flexion deformity also that happens. The Bowman angle will be increased in this cubitus varus, and crescent sign also will be there. So this is the gun-stroke deformity, as you can see. So there is a decrease in the carrying angle. The carrying angle is the angle formed by the long axis of the humerus and the long axis of the forearm, supinated forearm with the elbow in extension. Usually it is 5 to 10 degrees. One has to always check with the other side to compare. So gun-stroke deformity. So the treatment for this is French osteotomy, that is lateral closing French osteotomy, or modified French osteotomy, which is more commonly used. step cut osteotomy, dome osteotomy. Lots of osteotomies are there because this is a procedure with huge number of complications. So if it is purely cosmetic deformity, it's better and only mild, better to avoid the parents that to avoid osteotomy. If it is unsafety and to do those procedures, or if there is any difficulty in day-to-day activities, then one has to go for the lateral crossing and osteotomy. All other procedures that are advocated has not given good results in CUBITUS varus. So lateral crossing and osteotomy is treatment of choice. So CUBITUS varus treated by crossing and osteotomy to correct the varus. Now, neurologic injury occurs in 10 to 20% of cases. Anterior introductus nerve involvement is common but underreported. Median nerve is most reported, followed by radial nerve. And ulnar nerve typically occurs in flexion or due to iatrogenic injury due to the medial pinning. And so the treatment usually needs observation only for 3 to 4 months, even up to 6 months, because most of it is neuropraxias and it recovers without intervention. Now we come to the rare type of supracondylar fractures. This is the flexion type. It's only 2%. It is rarely seen. It happens when the child falls on the point of the elbow, and the mechanism is direct fall on the elbow with the distal fragment displacing proximally and anteriorly. Ulnar nerve injury is associated with this. It is very unstable in flexion. That is the importance of the supracondylar flexion supracondylar fracture. So one points on the point of the elbow, displaced anteriorly and proximally, unstable in flexion. So the classification is same here. Gartland classification itself. Type 1 is stable, and it can be treated by a long arm cast. Type 2, reduction in extension and immobilization in full extension for 3 weeks. If unstable, go for pinning. Type 2 and also type 3, pinning and followed by casting extension. So it is a deviation, extension, casting. Normally we don't do any casting extension, but in type flexion type of supracondylar, extension casting only gives stability. So one has to do it in extension, long arm casting extension. So the take-home points of the discussion is the supracondylar fracture is the commonest elbow fracture in children, and the types of supracondylar fractures, most common is extension type. The importance is due to the complications that can happen, especially the devastating complications that can happen. The Gartland classification and its modifications, the clinical signs and symptoms, the radiological signs and symptoms, and radiological signs that help in the treatment and diagnosis. The management of supracondylar fractures, we have seen the complications that are associated, and the management of complications also, and a brief glance on the flexion type also has been done. These are the references. Thank you.
Thank you, Dr. Sibi, for the presentation. Now the topic is open for discussion. Any questions from the audience? And we have our orthopedicians, Dr. Ajay sir and Dr. Rajesh Jain, who can add few points to the discussion. Thank you. Ajay sir.
Hello.
Yeah, you are audible.
Hello?
Please tell, sir.
Yeah.
Yeah, you can. We can hear you, sir.
Yeah.
Thank
good
you.
morning, everybody. One point which I would like to add is that supracondylar fracture, one of the dreaded complications, which is the vascular injury. So of late, it has been seen that for the sake of to be on the safer side, in case there is a doubt or a concern regarding any vascular injury, then a Doppler study is mandatory, so that we can be sure that the artery is normal or not, and this has to be recorded, so that in follow-up, if there is any vascular injury, that should be properly treated and managed by a vascular surgeon. So this is one of the most important things now, which is of late, like people handling supracondylar fractures have to really do that.
Yes, sir. Yes.
Thank you, Ajay sir. Any questions from the audience? Yes, Dr. Sibi, how often do you come across these patients in your OPD?
Type 1 supracondylar is very common here. Type 3 we see only rarely, once in a while.
Okay, okay.
One is big.
And majority are the type 1 and type 2, right? Majority
Yeah,
are? Oh,
majority are there, but type 3 is the one that causes most of the complication. But type
okay.
1 and type 2 also one has to keep an eye. We keep
Yeah.
regular follow.
Yes, Ajay sir also has pointed out the
Yeah.
pulsation and the nerve injuries. Any questions? If no more questions, we can conclude the session. So the post test as well as evaluation are posted in the chat box as well as in AHH WhatsApp group. Please fill up the post test and evaluation before concluding the session. Thank you all, and thank you, Dr. Sibi, and see you
Thank you.
all for the next Sunday CME.
Thank
Okay,
you very
thank
much.
you.